Part A. In this part of the test, you will hear a conversation between a general practitioner, GP, and a patient, Mr. George Clark, who is seeking advice for ongoing back pain. Now you have 30 seconds to look at the notes.
Good morning. Please come in and take a seat. How are you doing today?
Morning. To be honest, not great. My back's been giving me a hard time for quite a while now.
I see. Let's go over it carefully. You're here because of ongoing low back pain, correct? When did it start exactly?
It began roughly 3 months ago. It was right after helping my son move house. I remember lifting some heavy boxes and feeling a pull in my lower back that same evening. I thought it would settle down in a few days, but it never really did.
So, this started after lifting heavy objects. Did you notice any sudden sharp pain at the time, or was it more gradual?
It wasn't sudden, it came on gradually, more like a dull, nagging ache that just never left. It's always there, not sharp or shooting, just this constant, deep soreness.
That sounds uncomfortable. On a scale of 0 to 10, where 0 means no pain at all, and 10 is the worst pain imaginable, what would you say your current average pain score is?
Probably a 5 or 6 most of the time. Some days are better, but on others, especially after a long day, it's worse.
All right. Are there any particular activities or positions that make it worse?
Definitely. Standing for more than 20 minutes really sets it off. I can feel the tension building and I have to shift my weight or sit down to get any relief.
And what about sitting? Does that make it worse or better?
Sitting helps for a while, but after a bit it gets stiff. Then when I try to stand up, the muscles almost lock for a few seconds.
Has it been affecting your sleep?
Yes, that's been one of the worst parts. The pain wakes me up twice a night, especially when I roll over. I can't seem to find a comfortable position that lasts.
That must be exhausting. Have you noticed any tingling, numbness, or weakness in your legs at all?
No, nothing like that. It's just muscular pain, I think.
Have you tried any treatment or therapies for this before today?
Yes, I went to a chiropractor last month. They gave me some stretching and posture exercises and did a bit of manual manipulation. It helped for a few days, but then the pain returned just like before.
Sometimes those sessions can provide short-term relief, but not address the underlying muscle imbalance. Apart from that, have you used anything at home to help?
I use a heating pad almost every evening. I apply it for about 20 minutes before bed, and it definitely relaxes the muscles for a while.
That's good. Heat can be quite effective for muscular stiffness. Are you currently taking any medication?
I take paracetamol regularly, 3 times a day, and if it's particularly bad, I'll take some ibuprofen, but I try not to overuse it because I've got a bit of a sensitive stomach.
Understood. Has this pain affected your day-to-day activities, things like driving, working, or house chores?
Oh, definitely. Getting out of the car is difficult, and bending over in the morning to tie my shoes is practically impossible. The stiffness is always worst when I first wake up.
All right, let's take a quick look at your range of motion. Could you try bending forward gently for me?
Sure.
Okay. I can see there's a mild restriction in forward flexion of your spine, but there's no obvious nerve pain radiating down your legs, which is good news.
That's a relief.
For now, I'd like you to focus on staying active without overdoing it. The worst thing you can do for back pain is complete rest. Try to maintain 30-minute daily walks, just a steady, comfortable pace to keep the muscles working and prevent stiffness.
That sounds doable. I do enjoy walking in the evenings anyway.
Excellent. I'll also arrange for an X-ray of your lumbar spine just to check for any structural causes, things like early degeneration or vertebral alignment issues. Once we have those results, we can consider physiotherapy or targeted strengthening.
All right, I'll get that done.
And just to help with comfort, you can continue using the heating pad and paracetamol as needed. If the pain intensifies, let us know so we can review stronger options.
Thanks, I appreciate that. I've been trying to stay positive, but it's been wearing me down.
That's understandable. Chronic pain can affect mood and sleep, so staying active and consistent with gentle movement will really help. I'll see you again once your x-ray results are in.
Sounds good. Thanks for your time.
You're welcome. Take care of your back and we'll follow up soon.
Extract 2. You will hear a conversation between an obstetrician, Dr. Emily Carter, and a patient, Mrs. Lena Rossi, during her initial antenatal checkup. Now you have 30 seconds to look at the notes.
Good morning, Mrs. Rossi. It's nice to see you. I'm Dr. Carter, one of the obstetricians here. Congratulations on your pregnancy. Before we get started, let's confirm a few details. Based on your last menstrual period, you're currently 10 weeks pregnant, right?
That's right, doctor. I double-checked the date with my app last night, so that should be accurate.
Excellent. That gives us an estimated due date of December 5th. It's always exciting when we can already map out the timeline. Now, this is your second pregnancy.
Yes, my second. I already have one little girl. She's 4 now, and she's thrilled about being a big sister.
Lovely. So G2P1. Have you noticed any symptoms or issues with this pregnancy so far?
Mostly the usual things, morning sickness on and off. But lately I've had episodes of dizziness in the late afternoon, usually after I've been standing for a while or skipping snacks. It's not extreme, but it makes me need to sit down quickly.
Dizziness can happen early in pregnancy because of hormonal changes, but it's good to monitor it. Let's talk a little about your previous pregnancy. When was your daughter born?
She was born 4 years ago, in the summer of 2021.
And how was that delivery? Any complications?
It was a normal vaginal birth, no surgery or induction. Everything went smoothly at first, but right afterwards, I had quite heavy bleeding.
Yes, I can see from your hospital notes that you had a postpartum hemorrhage. We'll definitely keep an eye on that this time. Those who've had one before are a little more at risk of recurrence. Moving on to your medical background, any ongoing health conditions I should know about?
Well, during my last pregnancy, I was diagnosed with mild gestational diabetes. It was controlled with diet alone, no insulin or medication. I haven't been tested yet this time, but I'm trying to be careful with my meals, less sugar, smaller portions, that sort of thing.
Good to hear you're managing proactively. Any allergies to medications or food?
Yes, to codeine. It gives me severe nausea. I learned that the hard way after a dental procedure. I can't even stand the smell of some painkillers now.
That's duly noted. We'll avoid prescribing anything containing codeine. Let's touch on your family medical history. Any conditions that run in the family?
My mother is in good health, thankfully. My father, though, has high blood pressure and high cholesterol. He's on a couple of tablets for that every day.
All right. And any genetic or pregnancy-related issues among close relatives?
Yes, my sister suffered from preeclampsia in both her pregnancies. High blood pressure, swelling, headaches, the whole thing. It made me pretty anxious. I'm scared it might happen to me, too.
Perfectly understandable. We'll monitor your blood pressure closely and do regular urine checks to catch any signs early. Now, in terms of supplements, are you taking folic acid?
Yes, the 400 microgram dose every day, just like I did last time. I started it as soon as I found out I was pregnant.
That's ideal. Keep that going until at least 12 weeks. And about smoking, do you currently smoke or use any nicotine products?
I quit smoking cigarettes a few months before conceiving, but I still use nicotine patches occasionally, mostly on stressful days when cravings hit.
I'm really glad you stopped cigarettes, But even nicotine patches release the substance into your bloodstream, which reaches the baby. It's important to discontinue their use completely. We can refer you to our maternity smoking cessation counselor if you'd like support.
Yes, please, that would help. I want to do everything right this time.
Wonderful. I'll also arrange your first ultrasound for later this week. It'll confirm the gestational age and make sure everything looks healthy. Do you have any other questions or worries today?
Not really, just the usual new mom nerves, but thank you for explaining everything clearly.
You're very welcome, Mrs. Rossi. You're doing all the right things. We'll keep monitoring your progress, and I'll see you again at your next antenatal visit.
Question 25. You hear an extract from a hand hygiene policy announcement. Now read the question.
Colleagues, the hospital's latest compliance audit shows we're nearly faultless at sanitizing before and after a complete patient encounter. However, a noticeable lapse occurs when transitioning from a dirty to a clean body site on the same patient. For instance, moving from wound dressing to IV medication. This constitutes a critical failure to interrupt the chain of infection and is the current focus of our targeted retraining initiative. Remember, the 5 moments apply even within one continuous interaction.
Question 26. You hear an extract from a patient transport procedure manual. Now read the question.
For patients being moved off the ward for any imaging, nurses must fully complete the transfer checklist prior to the porter arriving. A key component often overlooked is the verification of the patient's NPO, or nil by mouth, status. While the porter is responsible for safe transit, the nurse retains full clinical accountability until the patient is formally accepted by the destination department, even if the porter is running behind schedule.
Question 27. You hear an extract from a blood collection protocol memo. Now read the question.
When collecting blood samples, if the initial attempt is unsuccessful, the protocol allows for a maximum of 2 further attempts by the same staff member. Crucially, beyond a total of 3 attempts, the collection must be stopped, and another appropriately trained colleague must be called to take over. This measure is in place purely to minimize patient discomfort and prevent unnecessary hemolysis, which can contaminate the sample.
Question 28. You hear an extract from a guideline on discharge planning. Now read the question.
Discharge planning should, as a rule, commence within 24 hours of admission for all non-elective patients. While most nurses diligently focus on final medication reconciliation and wound care instructions, the critical and most often delayed step is the coordination of necessary community services. This element requires the earliest possible notification to the social worker to prevent the costly issue of bed blocking.
Question 29. You hear an extract from an alarm management policy update. Now read the question.
Excessive and continuous alarm sounds within clinical areas have been identified as a major contributor to alarm fatigue, a condition where staff become desensitized to alerts, resulting in slower or missed responses to genuine emergencies. To address this safety risk, the hospital has implemented a structured alarm management protocol designed to balance patient safety with a calmer working environment. Under the updated policy, All non-urgent alarms, for instance, alerts triggered by a low battery warning, brief sensor disconnection, or temporary signal loss, must be acknowledged and silenced within 30 seconds of activation. This ensures that background noise is minimized while maintaining situational awareness. Importantly, staff are strictly prohibited from altering, disabling, or expanding the parameters of any high-priority or critical alarm, such as those monitoring cardiac rhythm, oxygen saturation, or ventilator function, without an explicit medical order or authorization from the responsible clinician. This safeguard prevents accidental suppression of alarms that may indicate potentially life-threatening conditions. All staff must complete the hospital's annual alarm response and prioritization training to ensure consistent adherence.
Question 30. You hear an extract from a mandatory incident reporting briefing. Now read the question.
All staff are now required to report every near-miss incident using the newly introduced electronic incident reporting system. A near miss refers to any event, error, or omission that had the potential to cause harm to a patient, visitor, or staff member, but fortunately did not, either due to timely intervention or sheer circumstance. The intent of this reporting process is not punitive. Instead, it represents a key component of the hospital's safety learning framework, encouraging staff to recognize and communicate risks before they lead to actual harm. Reports should focus on identifying systemic or procedural weaknesses, for example, unclear communication pathways, equipment malfunction, inadequate staffing ratios, or ambiguous protocols, rather than assigning personal fault. Information gathered through the EIRS will be anonymized and analyzed by the Risk and Governance team to detect trends, improve workflow efficiency, and strengthen safeguards across all departments. Staff are reminded that the primary goal is prevention and continuous improvement, not disciplinary action. By promoting open, blame-free reporting, the hospital aims to nurture a culture of transparency, accountability, and shared responsibility for patient safety. The measurable impact of this is profound. Patients with low health literacy are often unable to understand the labels on their prescriptions, the dosages, or the timing. This means the primary consequence is that they are frequently unable to successfully complete their medication regimens at home, which directly affects their recovery. They might miss appointments too, but the medication non-adherence is the most critical behavioral effect we see. To combat this, we advocate for the teach-back method. When you explain a treatment plan, ask the patient to explain it back in their own words. The power of teach-back is that it makes it your responsibility. It assesses the clarity of your own communication, not the intelligence of the patient. If the patient can't explain it back, you haven't explained it well enough. When preparing written materials, remember that simple language is paramount. You must replace all technical jargon with common everyday terms. Don't use hypertension. Use high blood pressure. While diagrams and clear headings are helpful, the most essential rule is eliminating the specialized vocabulary we use daily. A word of caution about translation. Always use a certified medical interpreter. Relying on family members to translate complex medical information is a risk, because they often lack the necessary vocabulary, or even worse, they may intentionally oversimplify the information, and key details are omitted because they are trying to protect their relative from bad news. This results in an incomplete picture for the patient. In conclusion, improving health literacy isn't just about patient comfort, it's about safety. It must be viewed as a priority for the entire team because it directly impacts the safety and quality of the care they receive post-discharge. If they don't understand how to care for themselves, the best treatment in the hospital is worthless.
You will hear an excerpt from a medical education podcast featuring an interview with Dr. Alex Grant, a consulting neurologist, discussing current guidelines and controversies in managing sport-related concussion. You now have 90 seconds to look at the questions.
Dr. Grant, thank you for joining us. We're focusing today on concussion management in the amateur sports world. What's the biggest barrier to proper diagnosis at this level?
It's multifaceted, but the single biggest challenge is the culture of downplaying symptoms. Amateur athletes, especially younger ones, feel pressure to stay in the game and will actively minimize or completely withhold symptoms like headache, dizziness, or confusion from their coaches or team staff. It's not the visibility of the injury. We know concussions don't always involve a blackout. It's the patient narrative that's flawed.
Once a concussion is suspected, what is the most significant change we've seen in acute management? We used to hear lights out, total rest.
Absolutely. The cocoon therapy, the total rest approach, is outdated. We now know that complete sensory deprivation can be counterproductive. The modern approach is to transition from an initial 24 to 48 hours of near total rest to a gradual sub-symptom threshold return to light activity. The major shift is moving away from total physical and cognitive rest and embracing an immediate but highly limited resumption of cognitive activity, things like light reading or screen time, as long as it doesn't worsen the symptoms.
And the return to play protocol, is the rigidity of that still necessary?
It is absolutely necessary. The protocol is staged precisely because we must avoid the devastating effects of a subsequent brain injury. The primary reason for its strict adherence is that rushing the process significantly increases the risk of sustaining a second, more severe concussion, known as second impact syndrome, which can lead to catastrophic long-term neurological damage. Each stage of the protocol is essentially a safety check.
What about patients whose symptoms persist for longer, perhaps 2 or 3 weeks?
This is where we see the most clinical error. When symptoms persist, clinicians often fall back on the idea of waiting for structural healing, maintaining strict rest. However, at this point, the issue often shifts. The greatest clinical error is attributing all ongoing issues solely to structural damage within the brain. We must assess for a vestibular, ocular, or psychological dysfunction, such as pre-existing anxiety or headache disorders, that may have been unmasked or exacerbated by the trauma. That is what needs targeted treatment.
Speaking of assessment, why has the vestibular ocular reflex testing become so important?
VOR testing, the eye movements linked to head movement, is critical because it isolates the mechanisms that often drive prolonged symptoms like dizziness or balance issues. Unlike a simple memory test, the VOR assessment is vital because it helps identify specific balance or gaze instability issues that require targeted physiotherapy intervention. It moves us away from vague advice towards specific treatment pathways.
And finally, who holds the ultimate sign-off responsibility for an amateur athlete's return?
While the coach and athletic trainer manage the day-to-day phases, the ultimate decision to clear an athlete for full contact must rest with the neurologist or sports medicine physician who has been managing the case. They are the only ones with the medical expertise to assess the underlying physiological readiness and the full diagnostic picture.
Extract 2. You will hear an excerpt from a clinical training session where a senior nurse educator, Ms. Evelyn Reed, is discussing common challenges related to patient health literacy with a group of junior staff. You now have 90 seconds to look at the questions.
Good morning, everyone. Our focus today is on health literacy, which is the ability of a patient to obtain, process, and understand basic health information. The biggest barrier we face isn't the patient, it's the misconception among us as staff. Many healthcare professionals still wrongly believe that low literacy only affects those who have a low level of formal education. The truth is, highly educated people can still struggle to understand complex medical language when they're anxious or stressed. That misunderstanding leads to poor communication. The measurable impact of this is profound. Patients with low health literacy are often unable to understand the labels on their prescriptions, the dosages, or the timing. This means the primary consequence is that they are frequently unable to successfully complete their medication regimens at home, which directly affects their recovery. They might miss appointments too, but the medication non-adherence is the most critical behavioral effect we see. To combat this, we advocate for the teach-back method. When you explain a treatment plan, ask the patient to explain it back in their own words. The power of teach-back is that it makes it your responsibility. It assesses the clarity of your own communication, not the intelligence of the patient. If the patient can't explain it back, you haven't explained it well enough. When preparing written materials, remember that simple language is paramount. You must replace all technical jargon with common, everyday terms. Don't use hypertension, use high blood pressure. While diagrams and clear headings are helpful, the most essential rule is eliminating the specialized vocabulary we use daily. A word of caution about translation: always use a certified medical interpreter. Relying on family members to translate complex medical information is a risk because they often lack the necessary vocabulary, or even worse, they may intentionally oversimplify the information, and key details are omitted because they are trying to protect their relative from bad news. This results in an incomplete picture for the patient. In conclusion, improving health literacy isn't just about patient comfort. It's about safety. It must be viewed as a priority for the entire team because it directly impacts the safety and quality of the care they receive post-discharge. If they don't understand how to care for themselves, the best treatment in the hospital is worthless.